Welcome, future nurses. In today's explainer, we're taking all that dense clinical information and transforming it into your ultimate NCLEX cheat sheet. We're going to do this by walking through a virtual mental health nursing shift. We aren't just memorizing facts today, we are learning how to actively think like a safe, effective nurse on the floor. Let's get into it. But before we even step onto the floor, I want to challenge you with a quick question. What is your absolute first priority for a mental health client? Well, as we'll see today, the ultimate NCLEX keyword is always, always safety. When you're staring down four multiple choice options that all seem completely viable, safety is the exact lens you must look through to find that correct answer. Keep this front of mind. Okay, here is the clear mental map of our shift ahead. We'll start with bipolar disorders and mania, move into depressive disorders and priority safety, navigate the complexities of anxiety levels, lock down GAD and panic attacks, and finally finish up with PTSD and trauma interventions. Section 1, bipolar disorders and mania. We're starting our shift with our highest energy patients, so let's look at how to rapidly assess and safely manage bipolar disorders. Think about the stark contrast here. You have bipolar I perfectly juxtaposed against the rapid-fire symptoms of mania, like pressured speech and an absolute inability to sleep. Picture your patient pacing the unit right now. Their mood is wildly unpredictable, their speech is nonstop with these intense flights of ideas, and they genuinely feel they are simply too busy to eat or rest. This is a super high-risk scenario because that boundless, urgent motor activity can completely mask their severe physical exhaustion. So when your client presents with these manic symptoms, your interventions have to be direct and hyper-focused on their physical well-being. You must reduce environmental stimuli immediately. Provide high-calorie finger foods, think sandwiches or protein bars, since remember, they are quote-unquote too busy to sit down for a full meal. And this is absolutely crucial. Maintain structured, solitary activities. This is definitely not the time for competitive group games, which can quickly escalate their agitation and impulsivity. Now let's talk about the pharmacological anchor for bipolar disorder, lithium carbonate. You absolutely must remember its narrow therapeutic range, the requirement for 2 to 3 liters of fluid daily, and toxicity signs like tremors. Because lithium acts just like a salt in the body, maintaining a stable sodium intake is non-negotiable. If your patient suddenly develops tremors, confusion, or severe GI upset, you aren't just looking at a minor side effect. You are looking at a clinical emergency. Section 2, depressive disorders and priority safety. Moving to the next room on our shift, the pacing slows down drastically as we assess patients with depressive disorders. The energy here is the complete opposite of mania, but the clinical risks? Just as critical. Anhedonia. You will definitely see this high-yield clinical term on your exam. It's the complete loss of pleasure or interest in normally enjoyable activities. And it's a critical assessment finding alongside low energy and decreased self-worth. When a patient tells you they literally no longer care about their favorite hobbies or seeing their family, that is anhedonia speaking. It's a massive red flag for a deeply depressed mood. And the NCLEX absolutely loves to test distinctions, so cement this timeline difference in your mind right now. Major depressive disorder requires a persistently low mood and symptoms for over 2 weeks, heavily impairing their daily function. Contrast that with persistent depressive disorder, or dysthymia, which is a chronic, mild depression lasting over 2 years. 2 weeks for severe, 2 years for mild. Lock that in. Now think about this clinical scenario carefully, because a sudden shift in mood isn't always a good thing. What is your absolute first priority for a depressed client showing sudden calmness? Imagine your patient has been deeply depressed and lethargic for weeks, and today they are suddenly peaceful, energetic, and maybe even giving away a cherished belonging. That sudden calmness often means the client has finalized a suicide plan. They feel a sudden sense of relief because they've made a decision. This makes safety your absolute #1 priority. You must ask them directly, are you thinking about suicide, and do you have a plan? There is absolutely no beating around the bush here. If the answer is yes, you immediately initiate one-to-one observation and remove all hazardous items from their environment. Section 3, navigating levels of anxiety. We're making great time on our shift. Next, we encounter patients dealing with varying levels of anxiety, which requires us to adjust our nursing approach dynamically based on the specific behaviors we're observing. First off, we have to distinguish normal, healthy stress from pathological anxiety. Pathological anxiety is disproportionate to the threat, persists even after the issue is resolved, and generalizes to non-threatening situations. Basically, it actively interferes with a client's daily life and requires our clinical intervention. Normal anxiety motivates you to study for a big test. Pathological anxiety paralyzes you from even opening the book. It's fascinating how this anxiety scale builds. A mildly anxious patient can still learn and problem solve. Their perceptual field is actually expanded. But on the other end of the spectrum, a patient in a severe to panic state has a completely distorted perception of reality. They are terrified, they might be hyperventilating or shouting, and they're risking exhaustion or even death if this intense sympathetic nervous system response is prolonged. Because of those stark physiological and cognitive differences, your interventions must shift to match. You want to encourage verbalization and problem solving for mild anxiety. But for severe to panic levels, teaching is completely out the window. You must use a calm, low-pitched voice, minimize environmental stimuli, and attend to their basic physical needs just to bring their physiological arousal back down. Section 4. GAD and panic attacks. Now let's look at two specific anxiety diagnoses and the exact algorithm you need to follow to keep your clients safe. Let's compare the two. You have the chronic excessive worry lasting over 6 months in generalized anxiety disorder versus the sudden, intense 5 to 30-minute surge of a panic attack where the client literally fears they are dying. GAD wears a patient down over months with muscle tension and sleep disturbances, while a panic attack is an acute crisis mimicking a heart attack with chest pain and choking sensations. Here is your NCLEX scenario intervention algorithm for anxiety. And I want to hammer home this absolute rule. Never, ever leave an anxious client alone. Providing a calm environment is great, but staying with the client is your priority action. Your calm presence provides the immediate physical and emotional safety that they simply cannot provide for themselves during a panic state. Section 5. PTSD and Trauma Interventions. We've reached the final rooms on our unit. For our last patient presentation on this shift, we are focusing on trauma and stressor-related disorders. Your assessment here will reveal a cluster of symptoms, including intrusive re-experiencing like vivid flashbacks or nightmares, active avoidance of reminders or places associated with the trauma, and severe arousal alterations like hypervigilance and an exaggerated startle response. The client's nervous system is essentially stuck in a constant state of high alert. Remember that flashbacks feel entirely real to the client. They are literally reliving the trauma in real time. Because of this, your calm presence is your most powerful tool. Do not startle them or touch them unexpectedly, and actively use the 5-4-3-2-1 grounding technique. Ask them to name 5 things they can see, 4 they can hear, 3 they can touch, 2 they can smell, and 1 they can taste. This gently pulls their senses right back to the present reality of the room. Beyond immediate flashbacks, long-term care involves heavily monitoring for suicide risk, utilizing specific therapies like cognitive behavioral therapy, or EMDR, and administering SSRIs as a first-line pharmacological treatment. We might also see medications like prazosin used specifically to disrupt those severe trauma-related nightmares. As we wrap up our shift, I want this rule burned into your memory. Safety is the #1 priority. Never leave an anxious client alone, and always assess for suicide. This is the ultimate cheat code for narrowing down your multiple choice options. Whenever you are stuck between 2 good-sounding nursing actions on the exam, ask yourself which one directly ensures the patient's immediate physical safety. You have the mental map, but here is your final challenge. If safety is always the #1 priority, how do you handle a situation where a patient's immediate safety directly conflicts with their personal autonomy? Keep studying, stay focused on that balance, and I will see you in the next explainer.